I'd like to present to you two novel spinal pain concepts. Since the late 1980s, I've been operating on patients with radiating spinal pain from either the neck or the back, with them in their aware state. In this condition, they are protected against pain by circulating painkillers and sedation, but able to tell us where the pain's coming from. This experience has been both enlightening and not a little humbling, because so much of what we learned in medical school and during training was incorrect. As you'll see from this image, the mobile segments of the spine comprise of facet joints at the back and the disc in the front, making a mobile segment, with the nerves leaving by an exit door called the foramen on both sides at each level. I've developed the method of endoscopic disc removal into the much wider operation of transforaminal endoscopic lumbar decompression and foraminoplasty, using an endoscope to traverse the foramen and operate on all the structures in the foramen and in the epidural area. The animation shows that the approach to the spine is by the posterolateral approach, rather than the conventional posterior approach, and allows better access to all of the nerve, the foramen, and across the inside of the disc. You'll see here in this animation the nerve in the foramen after scarring has been removed. The weak disc wall bulges in front of the nerve and displaces it, and to the top left of the image, the superior foraminal ligament has become bound to the nerve and is restricting its movement and its pulsatility. The novel and key finding during the operation, with the patients awake, was that touching the surface of the nerve caused local back pain, and deeper pressure was required to cause the pain to radiate into the buttock and leg, reproducing the symptoms of sciatica. These findings fly in the face of perceived wisdom, which considers that low back pain arises from the disc. However, aware state examination during these procedures revealed that the disc is only contributory when it's inflamed, and this is only found in 11% of the cases. The image here shows a summary of the sources of pain that we've encountered during endoscopy. We've been able to unravel the real mechanisms which cause back or neck or radiating pain. Pain production in the midline arises from irritation of the surface of the nerve. There are several mechanisms that can individually or in combination cause this. As you can see from the diagram, the superior foraminal ligament impacts upon the nerve and the junction box called the dorsal root ganglion, and it behaves like a guillotine. As disc degeneration occurs, the disc loses mass and the disc wall bulges and weakens. This may result in a significant outpouching or disruption of the wall, allowing the contents to disrupt or squeeze out into the spinal canal, all serving to irritate or compress the nerve. During the degenerative process, the loss of disc height causes the plates of the facet joints to override, and these repeatedly impact upon the nerve and irritate that nerve. Another mechanism arises from the development of bone spurs from the lax facet joint or disc wall, which then dig into and irritate the surfaces of the nerve. But above all is the finding that repetitive microtrauma causes microbleeds, and subsequent repair develops into scarring, so often undetected by MRI scans. This scarring tethers the nerve and prevents it from sliding away from the facet joint or bone spikes or the bulging disc. As the scarring and tethering of the nerve increases, the nerve is prevented from its natural excursion of 0.5 to 1.5 centimeters, and irritation increases as a result of resisted traction. Of course, the scarring is made worse by the scarring caused by prior open surgery. Nerve irritation can be compounded by the breakdown products within the disc leaking out of high-intensity zones or disc wall tears directly onto the nerve. The result is inflammation and swelling of the nerve within the constricting sheath of scarring. In addition, the displaced working surfaces of the facet joint become arthritic and widen, and the bone overgrowth reduces the space in the epidural canal and also within the foramen. At the same time, the laxity of the disc frequently allows the upper vertebra to slide forwards or backwards in reference to the lower vertebra. This distorts and further reduces the volume of the foramen and epidural space, with added irritation and compression of the nerves. These problems are conventionally treated by disc decompression or fusion or total disc replacement. By contrast, endoscopic minimally invasive spine surgery in the form of foraminoplasty addresses these problems directly. As you'll see in this animation, the use of manual tools through the endoscope, laser or radiofrequency ablation, enlarge and seal the working zone whilst removing existing scarring round the nerve and reducing post-surgical scarring. The technique allows the foramen to be effectively enlarged, the nerve to be mobilized, bone spurs and disc protrusions and extrusions to be removed, and disc walls to be sealed, or rehabilitating gels to be inserted, all through a 6 mm wound. Endoscopic foraminoplasty minimizes damage to muscles and blood supply to the nerves and damage to local structures, and facilitates post-operative rehabilitation with muscle balance physiotherapy using the Alexander technique and reformer Pilates, and so speeds up long-term outcome benefits. This understanding allows for long-term successful treatment of degenerative spinal disease as a whole, including failed back surgery, disc protrusions, extrusions and sequestra, osteophytosis, which refers to bone spur formation, lateral recessed stenosis and axial stenosis, which refers to bone compression and restriction of nerve function, degenerative spondylolisthesis, which refers to vertebral slippage and its infantile form spondylolytic spondylolisthesis, where there is a fracture, and so-called spinal instability or discogenic pain, and also high-intensity zones, leaking discs, perineural scarring, degenerative scoliosis, and failed cervical surgery. But please be aware that the label minimal intervention spine surgery or microdiscectomy can be misleading, because it refers to the practice of conventional surgery through a 3 to 6 centimeter wide wound rather than a really small 6 mm wound as we use in endoscopic minimally invasive spine surgery. And size really does matter, because smaller wound tracts and working zones cause far less collateral damage to tissues while still achieving the desired ends. The second concept I would like to highlight is cluneal nerve trigger point irritation. Over the last decade, I've noticed an additional cause of low back pain and sciatic-like symptoms occurring after pregnancy, trauma, unfitness and loss of postural control, and particularly amongst patients following conventional microscope-led disc removal or instrumented intervertebral fusion. As you'll see from the diagram, the cluneal nerves pass through trigger points in the paravertebral region or along the iliac crest. The pain arises from the cluneal nerves where they become kinked and irritated as they pass out of the strap muscles of the lower spine, called the erector spinae, or as they cross over the rim of the pelvis or come through the ligaments above the sacrum. The latter are often misdiagnosed as sacroiliac pain and lead to unnecessary sacroiliac joint fusion. These nerves have no motor function, they do not power muscles, but they do cause buttock pain and piriformis pain, trochanteric bursa pain, thigh, calf or shin, pins and needles, numbness or bursting symptoms, or pain and even symptoms like these into the feet, thus mimicking sciatica. And you can see this distribution in this diagram and see why it's so easily confused with sciatica. The diagnosis is confirmed by a reduction of pain following trigger point steroid injections. If muscle balance physiotherapy using the Alexander technique and reformer Pilates during the period of relief does not sustain the benefit, then radiofrequency ablation produces lasting benefit. This procedure is performed through several 1 millimeter needle puncture wounds. And both the transforaminoplasty and the cluneal nerve ablation procedures have very promising long-term success rates, still sustained 8 to 10 years later, and have been peer-reviewed. Please visit the Spinal Foundation website for further information so that you can discuss these findings and techniques with your endoscopic spine surgeon or chronic pain management specialist. I do hope that this has been of some help to you, and thanks for listening.